Good afternoon, everyone. This is John DeStefano from the England QIN-QIO. Thank you for joining us today for today's webinar titled Meaningful Use Updates, Stage 2 and Stage 3. We're excited to have participants from around New England attending today's webinar. Before we get started, there's a few quick housekeeping items. This call is being recorded. The recording, as well as an extended version of the presentation slides, will be available on the New England QIN-QIO website following the presentation. All registered participants will receive an email with instructions on how to access the recording and presentation material. The phone lines will be on mute for the duration of the presentation. We will take questions at the end, and I will provide instructions on how to unmute your line. Julia is a business analyst at Through her work with Connecticut's Regional Extension Center, eHealth Connecticut, she assists primary care providers in achieving meaningful use and applying for EHR incentive programs. At this time, I'd like to turn the presentation over to Julia.
Thank you for joining. We're going to dive right in because we have a lot on the slides. We're going to be skimming over a few of the repetitive measures that haven't had change to them, and of course, we'll take questions at the end. So first, we're going to take a polling question. Please indicate the setting in which you provide health care. A, primary care ambulatory, B, specialty care ambulatory, C, hospital, or D, other. Do we have results from our polling? Okay, so as you can see from the results, we have a mix of participants here, some hospital, some primary care, a few other, and a few specialties. Moving on. Start with the timeline. This proposed rule for Stage 2 will affect 2015 through 2017 if passed. For 2015, the big change will be that all have a 90-day reporting period regardless of stage in 2015, as it was in 2014. For 2016, new participants can still use that 90-day reporting period, but all else will have to use a full reporting period. And then in 2017, everyone will be on a full-year reporting period with the exception of those new Medicaid providers who may still use that 90-day reporting period. The reporting period will be based on the calendar year, not the fiscal year, and we will be continuing to use the 2014. You can upgrade prior to 2018, but nothing before that. Image of what stage you have the choice of being on, depending on when you began the Meaningful Use program. So this kind of highlights the biggest changes to Stage 2. There is going to eliminate the distinction between the core and menu measures. They are all essentially core measures. You must meet all of them unless you qualify for an exclusion. There are going to be 9 of these. Those providers that are still meant to be in Stage 1, there are exclusions linked out. Essentially, they removed many of the measures that they felt were redundant or that most were meeting 95%, 100%, just to kind of simplify things. There are no changes to the CQMs. It's still going to be 9 CQMs, 3 domains. And the biggest changes here we have for the patient electronic access. Rather than having at least 5% of your patients accessing the portal, you only need to have at least one patient. Makes it a lot simpler. Similarly, for the secure electronic messaging, it's no longer a percentage-based measure. It's going to be a yes or no question. You just have to have that functionality fully enabled. And then the other big change is the public health measures are going to be consolidated into one objective with different options, which we will be looking into in further detail. So here's a list of all those measures that are removed. You no longer have to report on these. Providers are still expected to be doing these things. It's just not going to be part of the attestation process. So as you can see, that's a pretty long list. Recording demographics, vital signs, smoking status, lab results, etc. These are just the measures that they felt that almost all providers were meeting, and it's really become unnecessary to track them at this point. So what's left? We have CPOE, e-prescribing, clinical decision support, patient electronic access, Protect PHI, patient education, medication reconciliation, summary of care, secure messaging, and public health reporting. So I've laid out each slide here. You can see on the left is the proposed stage 2 measure, and then on the right is for those providers still on stage 1. They have this limited exception where they may claim exclusions for some of these measures that they may not have encountered had the proposed rule not passed. So for CPOE, there's really no change here. As far as stage 2, it's the same as it would have been without the proposed rule. 60% of med orders, 30% of lab orders, and 30% of radiology orders are recorded using CPOE. E-prescriptions, once again, no change there. Clinical decision support, implement 5 clinical decision support interventions related to 4 or more CQMs, and then they've also combined the drug, and drug allergy interaction checks into this measure. Patient electronic access, as I said before, this is one of the big changes. While you still need to provide 50% of your patients access to their health information, only one patient has to actually view, download, or transmit that health information rather than 5% of your patients. Protect electronic health information, there's no change here. Continue to conduct that security risk analysis. Patient education, provide education resources to at least 10% of your patients. MedRec, once again, no change. Perform the medication reconciliation for 50% of your transitions of care. Summary of care, similarly, no change. When you are the recipient care, you create that summary of care record for at least 10%. The messaging is another one of the big changes. Like I said, you just have to have that capability for your patients to send and receive their secure. You don't have to prove any threshold of patients actually use that measure. For this one, you have multiple options. If you are on stage 2, you must choose 2 of the 5. Stage 1, you only need to select 1. So numbers 1 and 2 are familiar: Immunization Registry and syndromic surveillance reporting. Those are as they were previously. We just expanded some options: case reporting, public health registry reporting, and clinical data registry reporting. This is just to give providers more options of public health reporting that they can participate in. Attestation changes. So Medicare providers cannot attest prior to January 1st, 2016 for the 2015 reporting period. And then they're providing an option for providers who are eligible for both the Medicare and Medicaid programs who do not meet the Medicaid patient volume requirements. They can attest through CMS's RNA system in order to avoid the Medicare payment adjustment. However, they will not receive an incentive payment if they do this. We have our next polling question. For those practices participating in the Meaningful Use Incentive Program, please indicate if you will be submitting PQRS directly from your EHR or a DSC, if you will be submitting PQRS measures through a different means, or if you will not be submitting PQRS measures for 2015. Okay, can we see the results of the poll? Okay, so it looks like Most are using EHR Direct or direct submission vendors. Now moving on to the Stage 3 proposed rule. So as far as program changes go, there's an optional participation year in 2017 if you feel you're ready to start on Stage 3. And beginning in 2018, all providers will be reporting on the same definition of meaningful use regardless of prior participation. Medicare program participants must participate in a full year regardless of stage. First year Medicaid program participants can still use a 90-day reporting period. So from 2015 to 2017, as we said, you must use at a minimum the 2014 edition. No longer can use the 2011. You may upgrade to the 2015 edition prior to 2018. You may use a combination of 2014 and 2015 prior to 2018, but by 2018 you must be using that 2015 edition. And we're just going to skip through that. We already looked at that. So similarly to the proposed Stage 2 rule, there's just going to be one set of objectives, no core, no menu. They are similar here. We have Protect PHI, ERX, Clinical Decision Support, DPOE, Patient Electronic Access to Health Information. Then we have two new ones, Coordination of Care Net, Health Information Exchange, and then Public Health and Clinical Data Registry Reporting again. So as you'll see at the bottom of each slide, I've pointed out in red what is the change from Stage 2 to this measure, because once again, many of them are still similar. So the protecting of the PHI is the same, essentially. They've just kind of clarified the language here to clear up any confusion. This is to include administrative and physical safeguards, and they also clarified the timing of when you must conduct this security risk analysis. Electronic prescribing, there's no change here other than that the threshold has been increased to at least 80%. Once again, this is just permissible prescriptions, no controlled substances. Clinical decision support, no change here. Implement 5 clinical decision support rules. Computerized provider order entry, once again, not a big change here. The thresholds have increased, as you can see. Med orders are 80%, lab orders 60%, and imaging orders 60%. One change is that formerly in Stage 2, we were saying at least 60% of radiology orders. Now they've extended the language to say diagnostic imaging orders, so you can include additional methods there. Patient electronic access. This is one that has had quite a few changes. So the threshold has increased to 80% of patients at least. The patient wait time has decreased. So the patient needs to be provided their health information within 24 hours. And then the biggest thing here is the addition of APIs. So you have the option of providing your patients access to view online, download, or transmit their health information, whether through the portal or through an ONC-certified API. The second part of that measure is just incorporating the education resources through the portal or through the API. Now this is a new measure. They're calling it coordination of care through patient engagement. Use communication functions of your EHR to engage with patients or their authorized representatives about the patient's care. So the way this is set up is that providers must attest to all 3 measures, all 3 numerators and denominators. However, they only have to meet the threshold for 2 of the 3 measures, and that is your choice which 2 you choose. So the first measure is that at least 25% of patients are actively engaged with the EHR. They can do this by either viewing, downloading, or transmitting their health information, or accessing the ONC-certified API. The next measure is that at least 35% of patients a secure message was sent using the electronic messaging function of the EHR, or in response to a secure message sent by the patient. So the patient can send it, or the provider can send a response. And the third is that patient-generated health data or data from a non-clinical setting is incorporated into the EHR for at least 15% of all unique patients. So once again, providers are going to have to attest to all three, but only have to meet the threshold for two. Next, we have health information exchange. Similarly, attest to all three, but meet the numerator and denominator for just two. The objective here is that the provider provides a summary of care record when transitioning or referring their patient to another setting of care. They retrieve a summary of care record upon the first patient encounter with a new patient and incorporate summary of care information from other providers into their EHR using the functions of certified EHR technology. So for the first part, at least 50% of transitions of care and referrals, the provider that transitions or refers their patient to another setting of care or provider of care creates a summary of care record using the EHR and electronically exchanges the summary of care record. Measure 2, at least 40% of transitions or referrals received and patient encounters in which the provider has never before encountered the patient. The provider incorporates into the patient's EHR an electronic summary of care document from a source other than that provider's EHR system. And measure 3, at least 80% of transitions or referrals received and patient encounters in which the provider has never before encountered the patient. The provider performs a clinical information reconciliation, and the three parts to that include the medication allergy, and current problem list review. Finally, we have the public health and clinical data registry reporting. Stage 3 just kind of expands the options for meeting this. So you have three options of active engagement. The first is essentially just registering to submit data with that registry. The next is testing and validation, and the third is production. So it really depends on the registry you're using, what stage they're accepting. So for instance, in Connecticut, we have the Meaningful Use State Testing Portal, Immunization Registry, but at this point you can only use it to send test messages. So once again, you can choose from these 5 measures. However, you need to choose at least 3. So the first 2, once again, are Immunization Registry reporting and syndromic surveillance reporting. Then we have case reporting, public health registry reporting, and clinical data registry reporting. CQM reporting requirements will be addressed for 2017 and subsequent years in the Medicare Physician Fee Schedule rulemaking. The goal is to further align and avoid redundant or duplicative reporting across the various reporting programs. Reporting can be via electronic, which is preferred, or attestation, and EHRs will gradually be required to support all CQMs. That's all I have. I know that was a lot of information. We will now look at the questions.
Great. Thank you, Julia. So at this time, we'd like to take a few questions. If anybody has any questions, if they could type them into the chat window, we'd be happy to answer them. So we do have a question. Actually, we have a couple. So will the slides be available? And yes, they will. After the presentation, we will be posting them on the QIN-QIO website. We have an extended deck, actually, which covers a lot more material, and you can certainly use that as a reference. Okay, I don't see anything else in the chat window, so we have another one.
So they're asking about what is the frequency for the standard security risk assessment. We'll go back there. Where was it? Okay. So, upon installation of the EHR or upon an upgrade to a new version, the initial security risk analysis and testing may occur prior to the beginning of the first EHR reporting period. In subsequent security risk analysis of the EHR and make updates as necessary, but just once per. The next question is, do I have an idea of when the proposed rules will be approved? I know that the comment period finished a few weeks ago, so they're currently reviewing the comments. If I had to make an educated guess, I would say within a month, just based on last year's proposed rule. Of course, we will have that information as soon as we know it, pass it on to you. The next question, if providers communicate with each other via secure messaging, does that satisfy the measure, or does it have to be secure messaging with a patient? It has to be with a patient. So it could be, like I said, a response to a patient, or if you want to send a patient a message. See if I can find that slide. Yeah, so it can't be provider to provider. Is there a penalty for not doing a security risk analysis? There's not a particular penalty for that, but you will not satisfy meaningful use if you do not.
Okay, that looks like all the questions for any discussion or any other questions that participants may have. You can do that by pressing star.
A couple more came in.
Okay. Go ahead, Julia.
For the public health measure, can you go over the current rule that you're expected to submit to, depending on your stage, 1 or 2 registries pertaining to your practice, or you meet the exclusion for enough, then yes, you can claim the exclusion. However, if there are existing registries that you qualify for, you will have to meet that. I hope that makes sense. If a provider is currently excluding the public health options, are they required to take on other new public health measures? Similarly, like I said, if there's that you can submit to, you are expected to do so, but if they don't exist, of course you can't. I'm thinking that more are going to start popping up if the proposed rule passes, because as of now in Connecticut we don't have a lot of options, but of course there will have to be in order to make this measure meaningful at all. Next question, to clarify the portal measure, 50% of all patients seen during the reporting period must be signed up for portal. They don't have to be signed up. The measure is still the same as in stage 1. They just have to be provided access, which essentially means that they have all the information necessary to sign up if they so choose. So generally this means that they have the URL and maybe a PIN or some kind of code in order to sign up that they received from the practice. Then let's see. You stated that Medicare providers can't test until January 2016, so does that mean we are all reporting for fourth quarter 2015? Well, I would say because proposed rule hasn't passed yet, and we're halfway through the year, you'll probably be doing fourth quarter. That would make sense. But I suppose if you happen to meet all those measures at a different time. Any other questions?
Okay, well, thank you everyone again for participating. I have just a few last-minute announcements before we end today's call. So when you close out of this webinar, the evaluation will automatically pop up on your computer. If you could fill this out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you will receive an email tomorrow morning with a link to the evaluation, as well as the link to the event page on our website. The PowerPoint presentation will be posted on the event web page within the next few business days, and a recording and transcript of this webinar will also be added. For our hospital participants, we are providing a webinar on the changes to the Inpatient Prospective payment system for fiscal year 2016 very shortly after the final rule becomes official. We expect the rule to be in place in August, and the webinar will be provided sometime in September. Thank you again for attending, and have a great day.